Welcome back to Medical Monday. I'm Carrie Sharp along with Dr. James Gray from Tennessee Oncology. We're so glad you're with us tonight. Dr. Gray is a radiation oncologist. So if you have cancer, you know someone who does, and they're having radiation as part of your therapy, that's what we're talking about tonight. We have Teresa on the line. Oh, heck. Teresa, are you there with me?
Yes, I am. Sorry, I lost you a while ago.
That's okay. We're glad you called back. What's your question tonight?
I'm in 5 years so far remission, and I had rectal cancer, and it's something sarcomas or something like that. But I was wondering, with the radiation that was going through the front, because I had 25 rounds, and it gave me third-degree burns, and ever since then, I can't even walk the mall without my hips hurting real bad, and I can't do anything further than with that. And I was wondering if the radiation has something to do with that.
What do you think?
Well, it's hard to say. I'd have to know exactly how your radiation was delivered. You said you had radiation in the pelvis?
It was for the rectum. I had rectal cancer that grew out, but they done the radiation to the front, to the back.
Right, and that is typically how we'll do that, although in today's world, because of the technologies that I just mentioned, we usually bring the radiation from at least 4 different directions to treat rectal cancer. But radiation is one of the mainstays of treating rectal cancer. We found that it is one of the essential components of a multimodality way of treating rectal cancer. It usually involves radiation and chemotherapy and surgery, but that doesn't apply to every patient.
Teresa mentioned this a couple of years ago, and you have mentioned how things have evolved and changed and different therapies are out there. When that radiation isn't exactly direct, there, I would assume, can be effects on other parts of the body.
You always do. I mean, that's the challenge of radiation therapy, is that the radiation energy has to also impact healthy tissues. And so, for example, when we're treating a rectal cancer, we have to treat the rectum itself, but it defines limits on how much radiation we can give and not damage the rectum itself. But the bladder is nearby. There are other tissues nearby. I'm surprised to hear that she had that much burning. I have seen that, but that is a relatively unusual circumstance, but it can happen. And without knowing her specifics, I couldn't say why it would have happened there.
All right, Teresa, thank you for calling in. We're glad that you are cancer-free.
Thank you. So far, 5 years.
All right.
That's
very good. Thank you very much. Let's go to Clarence now. Clarence, thank you for being with us. What's your question?
I had prostate cancer about 10 years ago, and there was 3 ways of doing this. Radiation, the grind, and the operation. I took the grind, and I never did take no pill, no therapy behind it. I take a shot every 6 months.
Okay, and what's your question?
I want to know why I didn't take any radiation.
It always depends upon the specific presentation. Some men will present with prostate cancer, and it may be in some other places besides the prostate. It can be in tissues nearby, or it can be in bones or lymph nodes. And in circumstances like that, the radiation might be able to help. It has to be individualized, but it's not always going to be the right thing to do to give radiation when we're using something usually called hormone blocking therapy. We don't usually step immediately to chemotherapy for prostate cancer, but that's because the hormone blocking treatment is usually very effective for prostate cancer if it is not localized, and it depends upon what presentation that was. If it was only in the prostate, there's other factors that can come into play, is decide whether or not we would use surgery or radiation or both. So it depends upon the specifics there.
All right, Clarence, thank you for calling in tonight. We appreciate hearing from you. Let's talk a little bit about prostate cancer, because this is a topic that gets a lot of men uncomfortable. And I imagine by the time that they see you, they're kind of past the uncomfortable stage and they just want to be well and they want to be cured. But let's back up, because prostate cancer is very treatable, but a lot of people don't want to go in for that first test. It's the test that guys talk about. What's your word of advice to men?
Well, there's a lot of controversy now in what we call screening for prostate cancer. The test, I think the test you're referring to is the digital rectal exam, which is an uncomfortable exam, but it's not a huge deal. But men also, one of that test could include the use of the chemical blood test called PSA, or prostate specific antigen. And it's called prostate-specific antigen because it is very much that. It is specific to the prostate. It's measurable in virtually all men, but it can be elevated in certain circumstances like enlargement of the prostate, infection of the prostate gland, and it can also be elevated when a man has prostate cancer. So we monitor the elevation of PSA to know whether or not we need to look more carefully to see if that gentleman has prostate cancer. But that technique, that way of checking men who otherwise don't seem to have prostate cancer and to see if maybe they do is called screening. Just like we do mammograms for breast cancer, colonoscopies for colon cancer, pap smears for cervix cancer. All of these are very effective tools. PSA screening for prostate cancer has been challenged recently by a lot of different scientific communities to say that maybe that's not the right thing to do. Maybe we're finding prostate cancer, but we're finding prostate cancer that otherwise was not going to be aggressive and dangerous to that man. So the United States Preventive Services Task Force, which was funded by the government to look at what does this mean, looking at different studies that have been conducted in the United States and primarily in Europe as well, to say when we routinely check men for prostate cancer by drawing that PSA blood test and doing the digital rectal exam, does that actually lead to a better survival down the road? And the conclusion from that organization was that no, we're not actually helping men out.
Wow.
By drawing the PSA, we're not actually doing them any favors. It was their conclusion that the use of PSA was actually exposing men to therapies that could then bring on side effects or complications when if we had just left them alone, they would have lived just as long. I understand the point behind those conclusions, but I disagree with them on several points, and a lot of that has to do with the quality of life of these gentlemen. When we treat some of the earlier stages of prostate cancer, I talk very bluntly with my patients about the fact that that won't necessarily make him live longer, but my goal is to make sure that his prostate cancer won't grow and progress and cause problems. And he may live the same amount of time with his cancer as he would if I get rid of his cancer, but I don't want the cancer to progress, cause him problems, force us to use other therapies to maintain control of the cancer as it progresses and grows. And therefore, the quality of life of the man is absolutely as important as the quantity of his life. And I believe that the task force, when it looked at that, wasn't able to actually analyze for those points. That's a much more difficult scientific endpoint, if you will, to gather information on. What is quality of life? Define that. Well, there have been efforts to define that and catalog that, but survival is a very easy point to catalog.
Yes.
You just have to have death certificates, frankly. It doesn't matter why they died even. It just matters that did they die or not. That was where their recommendations were based upon. And of course, that is the single most important endpoint in oncology is what is our ability to extend life. But if you can extend quality of life, even if you're not extending the actual duration of life, that's a very worthwhile goal in and of itself.
Sure, you want a life that matters. That's,
Right.
I think no one would argue with that. Let's go to James. Oh, I keep pressing the wrong button. I've got to get used to this new phone system. James, thank you for being with us and holding. What's your question tonight?
My question is, I've recently been diagnosed with prostate cancer, and I have been told that some of the major insurance companies in Tennessee, Blue Cross Blue Shield, Cigna, will not pay for the newer proton beam therapy to treat this cancer. And has there been any movement toward them paying for this? I've heard it's even been proposed in state legislature where they were to be forced to pay for it, but nothing has been voted on or approved yet. Does Dr. Gray know anything about that?
Well, that's an interesting question. That can be very frustrating.
I'm familiar with it a little bit. It hasn't been something that's been at the front of my mind because I haven't frankly been able to offer proton therapy to my patients here in the mid-state region. I have referred patients to Knoxville, to other places like Houston, Texas, MD Anderson, University of Florida, University of Pennsylvania, because they have access to these facilities, this type of equipment, for some time now. In Tennessee, it is the current stance of most of the commercial payers that they are not willing to pay for prostate cancer and many other types of cancer treatment with proton therapy, and is their contention that we have not yet demonstrated that there is a clear advantage with using proton beam. So the legislation that I'm familiar with that has been introduced has been an attempt to make sure that when the commercial insurers look at the use of proton therapy, that it is at least judged on a fair basis. In other words, the insurance companies have said, we don't want to pay for this because we don't have what is called in science level 1 evidence, which means randomized controlled trials in research, which means you have to have many men in, for example, in prostate cancer, you have to take a lot of men, randomly assign them to get radiation therapy that might be considered the normal or standard of care versus radiation therapy with a newer, promising mode of care such as proton beam, and randomly decide which treatment they get, watch these men over probably a decade or more, and then report back to see what happens. Well, the problem is that takes literally many, many millions of dollars to conduct these trials. A lot of men don't want to enter the trial because there is there certainly seems to be a potential advantage to using protons in this situation. So a lot of these men don't want to open themselves up to being randomized to the old-fashioned way of doing it, even though that is an excellent way of doing treatment. And we honestly don't know which is better. So as scientists, we want to have the answers, but at the same time, we have to be able to treat the patients to be able to get the experience and have the answers. It's upon us to design and conduct these trials as well as we can. Randomized controlled trials are some of the absolute framework and foundation of how we make our best decisions about how we move forward. So I understand the insurance company's point of view with this. They see this as raising expenses, yet not necessarily improving the care of their patients. The legislation that's been introduced, as I understand, is absolutely not a mandate. I don't believe in mandates either for insurance companies. I think, though, the insurance companies should judge this on a fair and even basis because they have paid for more advanced technologies historically without demanding that level of evidence. So allow proton therapy to be promoted and advanced under the same guise that we have done with other advances in radiation therapy over the years. And that's the only legislation I'm aware of, unless there's some others that I'm not aware of.
It's an interesting catch-22 that I didn't know about until James called that.
It's like the person who says, I want a job, but you won't give me a job because I don't have experience.
Right, exactly. And when it's your life and your livelihood, you want the best of the best. And if you're willing to say, okay, this is out there, I want to give it a try, but we're not going to pay.
Right.
Yeah, that's frustrating. James, thank you for your call. Thank you for bringing that topic to our attention. Clyde, Marion, and Lucy, I know you're on the line. As soon as we get back from this break, we're going to take your call, so stay where you are.